So friends, welcome to today's session of critical care webinars. Today is session number 128, and I'm glad that you are finding this useful. So it encourages us to go on, and we shall continue to provide educational video material for all of you. For those of you who may not know me, I am Dr. Tapesh Bansal, and I initiated this program along with my co-faculty members, and thank you for your response. So the topic today is pulmonary embolism, and we will just start. I'll share my screen. So this is Rudolf Virchow, who discovered or coined the term venous thromboembolism in 1850s, and the classic Virchow's triad is named after him. Pulmonary embolism is a common cause of death which is found at autopsy. So unexpected deaths, and you do autopsy, pulmonary embolism is not uncommon. So always think of it in cases of sudden deterioration, sudden deaths. The incidence of pulmonary embolism is going up because of the population in which pulmonary embolism occurs is increasing, such as old age, cancer patients with comorbidities, and so on and so forth. But with improved treatments, mortality has gone down. So when do you suspect pulmonary embolism? So the patient is in the ICU, there's a drop in saturation, there's a drop in blood pressure, sudden onset atrial fibrillation, or he may be asymptomatic with small pulmonary emboli. Then what are the clinical features? So the commonest clinical feature is chest pain, dyspnea, and sometimes they can be chest pain because of pleural infarction, and rarely you may have cough, syncope, hemoptysis, and fever. The signs, commonest sign is actually tachycardia and tachypnea. Occasionally, you may get some cramps and rhonchi, and if there is DVT, you may get leg pain or swelling, though it's not necessary to get leg pain or swelling if there is DVT. Rhonchi occur because often there is bronchospasm associated with it due to release of certain mediators like serotonin, and crepitations do not occur immediately, but after around 12 to 24 hours, due to atelectasis, due to some degree of pulmonary edema, you can get crepitations. However, the most important thing is risk factors, whether the patient has risk factors, so that leads us to suspect pulmonary embolism. So what else can embolize? What is the differential diagnosis for pulmonary embolism? So as to say, sudden onset dyspnea and hypotension, fat embolism, which occurs in the setting of trauma, then amniotic fluid embolism, which is a very important differential in pregnant females because they are predisposed to pulmonary embolism. Then there can be cancer emboli, tumor emboli, which behave like pulmonary embolism. There can be air embolism, especially in surgical patients. There can be IV drug abuse patients who can be predisposed to emboli of material they are injecting, and cement and bone can also embolize in patients who undergo arthroplasties. Now, what is the cardiac physiology for pulmonary embolism? So, here, as you can see, there is increased RV afterload because the pulmonary circulation gets obstructed by the emboli, and this leads to RV dilatation because the RV is very susceptible to pressure overload. So it's unable to pump out the entire blood during systole, and there's RV dilatation. Because there's a stretch on the RV, the wall tension increases. And there is a increased oxygen demand because the work of the RV is increased. It has to pump against increased pressure, and this leads to some degree of RV ischemia, and there's a decreased contractility. Because of this, there's a decreased RV output, and because RV output is decreased, the LV filling is decreased. The LV filling also decreases because the interventricular septum in extreme cases starts bulging towards the LV, thereby decreasing the LV filling. Once the LV filling decreases, there's a decreased cardiac output, decreased blood pressure, And because the right ventricle perfusion is dependent upon the systemic blood pressure, there is decreased oxygenation of the right ventricle. So along with the fact that the right ventricle requires more oxygen because more work is required of it, there is decreased oxygenation also. So this leads to RV ischemia, and this is a continuous spiral. As you can see, this is a continuous spiral. As there's a decreased oxygenation of RV, its pumping decreases further leads to decreased RV output, and further decreased blood pressure, increasing pressures in the RV, increasing oxygen demand, and it continues to deteriorate downwards like a spiral. As far as pulmonary physiology is concerned, uh, you have this basic physiology in hemodynamics because there is increased pulmonary vascular resistance. Then, as far as gas exchange is concerned, there is increased alveolar dead space. The dead space increases because alveoli are ventilated, but there is no blood supply in this area as there is obstruction by the emboli. This leads to hypoxemia. And there is an increased respiratory rate most of the times. The respiratory rate increases because of increased respiratory reflexes because of pulmonary embolism. And it is very rare to get hypercapnia in patients of pulmonary embolism. Most of the times, either there will be a normal CO2 or a decreased PCO2. A high PCO2 is seen generally in patients with underlying lung disease such as COPD. Now, how do you diagnose pulmonary embolism? So, pulmonary embolism is diagnosed and suspected on the basis of clinical features. An age-adjusted D-dimer, I shall talk about this. Electrocardiographic changes, imaging, chest X-ray, ctpa, ultrasound limbs, echo, VQ scan, and pulmonary angiography. So the D-dimer, as you all know, helps in ruling out pulmonary embolism. It has a sensitivity and specificity of 95% in ruling out pulmonary embolism. So what is new about D-dimer is that a new cutoff has been suggested. Earlier cutoff was 500, but now for patients over 50 years of age, you have to take the cutoff as age into 10. So if he's 70 years old, the D-dimer cutoff becomes 700 nanograms per ml. Now, what about the ECG? So you have all heard about S1, Q3, T3. And you can see here, this is the S wave, and this is the Q wave, and this is the inverted T wave. However, this is seen in only 10% of the patients, but it is highly specific for pulmonary embolism. It actually indicates acute right ventricular strain, but it is seen only in 10%. What are the other clinical features? So other clinical features which are more common and probably the commonest is sinus tachycardia. Then you have right ventricular strain, that is T wave inversion V1 to V3, RVB, sudden onset atrial fibrillation, and shift to right axis. So this ECG here is showing what? This is showing RV strain. So T wave inversion in V1 to V3. So that is RV strain. S1, Q3, T3 is also a feature of RV strain. Then coming to X-rays in pulmonary embolism. So this is one kind of X-ray you get. And what is here in this? This is an elevated hemidiaphragm. And what is this due to? So this is due to a subpulmonic pulmonary effusion. And this here is, what is this here? This here is a relative area of lucency known as Westermarck sign. And this occurs because there is obstruction here by the clot, there's no blood flow, so this becomes lucent. And what is this here? This here is an infarct. As you can see, this is a wedge-shaped opacity, and this signifies an infarct, though infarct does not have to be wedge-shaped. It can be irregular in shape, that is consistent with an infarct. So this is another CT and X-ray showing Westermarck sign. As you can see here, this is radiolucent, while this has bronchovascular markings. Becomes radiolucent because there is no blood flow. And here you can see in the same area on the left side, there is a significant embolus in the ctpa. Now, this is known as Hampton in a patient with suspected pulmonary embolism, and it shows again a wedge-shaped opacity in the lateral segment of the middle lobe. And here again, you have the corresponding CT showing the pulmonary emboli, and this is the wedge-shaped infarct. Now, coming to the question of pregnancy, should we do CTs and X-rays in pregnancy? So it's all right to do CTs and X-rays in pregnancy, provided the index of suspicion is high. It does not harm the fetus, and the radiation with current generation CT scanners is quite low. The role of X-ray in pregnancy is mainly to rule out any other pathology, and that is generally the role of X-ray, to rule out any other pathology, because X-rays are generally normal when you do it at the time of pulmonary embolism. So after 12 to 24 hours, in some patients, you may get some degree of infiltrates due to pulmonary edema or because of atelectasis. Now, this is a VQ scan, which is not so commonly done. It's restricted to certain conditions. And the most common indication is if IV contrast cannot be given. So if the patient has nephropathy, you may not like to give IV contrast. And there you do a VQ scan. And in a VQ scan, you see perfusion and ventilation. So this is a perfusion scan. And you can see this is not perfused. This is because of the embolus here in this area, while ventilation is preserved. So there's a mismatch between perfusion and ventilation, and that indicates an embolism. So if you get a mismatch in perfusion and ventilation, that indicates mismatch. If it is matched, in the sense the same area has no perfusion and no ventilation, then you cannot comment on it. So VQ scan is useful in certain situations, like those conditions where IV contrast cannot be given or ctpa cannot be done because of certain reasons. However, if the X-rays are abnormal from before, then it becomes difficult to interpret VQ scans. This is an example of pulmonary angiogram, and pulmonary angiogram is generally done with technically unsatisfactory chest CTs, or those in whom an interventional procedure such as catheter-directed thrombolysis or pulmonary embelectomy is planned. As you can see, there's a filling defect here signifying pulmonary embolism. Now coming to echo. So acute cor pulmonale is what you get in pulmonary embolism if there is RV dilatation, acute RV dilatation. And as you can see here, there is RV is dilatation. Again, in the four chamber view, RV is increased, appears larger than LV. And there's a TR here in this particular view. Measure the ratio between the right and left ventricular and diastolic areas. And RV dilatation is a diastolic ventricular ratio greater than 0.6, and major right ventricular dilatation as a diastolic ratio greater than 1. So that is how you actually go about seeing RV dilatation on echo. And this shows the septum bulging into the LV. So normally the septum bulges into the RV. It's a D shape going towards the RV. This is the LV. And in patients of extreme acute cor pulmonale, where the RV pressures are high, the PA pressures are high, the septum starts bulging towards the LV. So this is in diastole and this is in systole. And here, once the septum starts bulging into the LV, the filling of the LV is further impeded and LV output decreases. Diastolic filling of LV gets restricted. So this here is McConnell sign in pulmonary embolism. And what happens in McConnell's sign is that you can see here, this is hypokinetic, this is the RV, and this is hypokinetic, while this inferior basal portion is hyperkinetic. So this is McConnell's sign, and it is highly specific for acute cord pulmonale. Now coming to biomarkers, tropi is positive in around 50% of the patients and puts patients in high or intermediate risk category. As far as BNP is concerned, a normal value of BNP makes pulmonary embolism unlikely. However, it is not diagnostic in the sense you cannot use it for ruling out. You have to do a ctpa to kind of confirm the pulmonary embolism. So BNP is just an additive marker. Now, a very interesting thing is how to make the diagnosis from the ventilator. Often patients are on the ventilator and they deteriorate, and you suspect pulmonary embolism. So, this is a situation where the patient is on the ventilator. So, what will happen after pulmonary embolism to the ventilator data? So, you see, pulmonary embolism is a vascular phenomenon. Pulmonary embolism occurs within the pulmonary vessels. The lung parenchyma, as such, is not affected, nor are the airways. So, minimal change in ventilator data and peak and plateau pressures remain almost the same. So, if there's a fall in saturation with fall in blood pressure, or just a fall in blood saturation, and the ventilator data remains more or less the same, there can be some change in peak and plateau depending on what kind of mode you are using and settings, because the respiratory rate can go up. Often it goes up. So that can change the values a little, but there'll be no major difference in peak and plateau pressures. So that is one of the hallmarks of making out pulmonary embolism from the ventilator. If the patient has embolism on the ventilator, patient will desaturate and may have hypotension, but there'll be very little change in your ventilator data. So occasionally, you may get bronchoconstriction. Bronchoconstriction is known to occur with pulmonary embolism because of release of serotonin and other mediators. In these situations, there may be some bronchoconstriction and rise in peak pressure, but that is not the norm. Most of the patients will have a almost normal peak and plateau pressure without any significant change. So what is the diagnostic algorithm for suspected PE? So you do a bedside echo, and if there is RV dysfunction, well and good. If there is no RV dysfunction, you rule out. So if there is hemodynamic instability, you cannot have a normal echo. A normal echo in a patient with hemodynamic instability rules out PE. So if ctpa is feasible and available, feasible because patient may not be shiftable. So in situations where you do an echo and you get RV dysfunction, but cannot do a ctpa, you are justified in treating the patient on the basis of your RV dysfunction. ctpa is not a must to treat such patients, and you can go ahead with thrombolysis. If ctpa is positive, you do a ctpa. If it's positive, you go ahead with the treatment. If it's negative, you have to search for other causes. This is a scoring system which is simplified pulmonary embolism severity index. And you can see here single points are given for different conditions: pulse rate, systolic BP less than 100, saturation less than 100, and so on and so forth. And this actually gives you the risk for mortality at 30 days. So if there are 0 points, the 30-day mortality is around 1%. And if it's more than or equal to 1 point, your mortality risk is 11% at 30 days. This is the Wells score, which gives the pretest probability of deep vein thrombosis. This is the classic Wells score, and now you have the modified Wells score. So in the modified Wells score, another clinical feature has been taken into account. That is a previously documented DVT, and is given the score of 1. So using this modified scoring system, DVT is either likely or unlikely. So likely 2 or greater points, and unlikely 1 or less points. Now this is a classification of PE based on early mortality risk. So it is divided into high, intermediate, and low risk. Intermediate is intermediate high and intermediate low. So high is essentially hemodynamic instability and RV dysfunction on echo or ctpa. Intermediate will not have hemodynamic instability, but the PESI score will be or greater than or equal to 1, and the other features will also be positive, especially troponin is important here. And then in low risk, nothing will be positive. So this is a stratification on early mortality risk, and the treatment is actually based on this. This is a very important stratification given by European Society of Cardiology 2019, which are the latest guidelines on the management. There is no other guideline after that actually, which is more specific than this. So now that was about hemodynamic instability we had talked about. What about patients with acute PE in general? So once you suspect PE in general, anticoagulate the patient. And if there's hemodynamic instability, that is high risk, you go on to reperfusion treatment with hemodynamic support. If intermediate high risk, then monitor, consider rescue reperfusion if deterioration. If intermediate low risk, you have to hospitalize and again continue to monitor. Generally, these patients do not deteriorate. And if low risk, then no other feature is present, you can consider early discharge and home treatment. So it is very important to diagnose pulmonary embolism accurately and stratify the risk. And 15% of the patients do not respond to your thrombolysis. And it is very important not to harm the patients because there is a significant risk of bleeding. And I should be very careful in choosing your anticoagulation and thrombolysis strategy, and be aware of renal failure, because if you're going to anticoagulate, then renal failure becomes a consideration, especially if you are using low molecular weight heparin. So the treatment options apart from thrombolysis are anticoagulation, catheter-directed treatment, management of acute right ventricular failure, pulmonary thrombectomy, ECMO, and IVC filter. So first of all, what is the basic treatment? So you give heparin or low molecular weight in all. Better avoid low molecular weight heparin if in hypertension or severe PE, because renal functions are going to get deranged and there's a risk of bleeding. So the dose for thrombolysis is alteplase 100 milligram over 1 to 2 hours, and that is if there is hypotension only. Classically, you can use tenecteplase also, or you can use streptokinase if you want, but streptokinase efficacy is not so much. Alteplase is the drug of choice. So now you have given alteplase and you want to start anticoagulation. So some people like to do a PTT before starting heparin or low molecular weight heparin, but others continue immediately after stopping alteplase. So school of thought is divided on this, how to proceed. Then switch to dabigatran 150 milligram BD after 5 days. And then you maintain oral anticoagulation minimum 3 months in all patients, and then depending on the cause, etc., there can be prolonged anticoagulation with oral anticoagulants. Be aware of the complications of bleeding and what are the contraindications to anticoagulation and thrombolysis. Contraindications, some general contraindications are INR of greater than 1.5, APTT greater than 1.5 times, platelets less than 50,000, any active bleed, and there's a long list of checklists. You should go through that before starting anticoagulation. And thrombolysis is indicated if the BP is less than 90 for more than 15 minutes or the patient is in shock. Check all contraindications again for thrombolysis. Pregnancy is a relative contraindication, and post-surgery again, for 2 weeks after surgery, you cannot thrombolyze classically. Please be aware that the risk of bleeding is very serious. 9% have serious bleeding and 3% have intracranial hemorrhage. And we have had patients who have had intracranial hemorrhage, resulting in fact in fatal outcomes, despite all precautions. So be very careful in using anticoagulation and thrombolysis in patients of pulmonary embolism. As far as intermediate and high risk patients are intermediate high risk patients are concerned, they have to be followed up because they can deteriorate. And if they deteriorate, then you have to go in for thrombolysis. And if there is failure to improve with thrombolysis within the next few hours, then you have to consider an alternative mode of treatment, such as pulmonary embelectomy or catheter directed removal of the emboli or catheter directed thrombolysis. Now, coming to treatment of acute cor pulmonale or acute right ventricular failure. So we have ventilation, fluids, cardiac output, blood pressure, arrhythmias. These are the main issues that have to be tackled in acute right ventricular failure management. Because though you have thrombolized the patient, the acute right ventricular failure also has to be managed simultaneously. And sometimes you may not be able to thrombolize, may not have the facility to do pulmonary embelectomy. So there you may just have to manage with your basic management of acute right ventricular failure. So here you have ventilation. So ventilation, these patients should be managed with the lowest airway pressures. Try to do with NIV, but if you have to intubate, then you have to intubate and put the patient on mechanical ventilation. Initially, try to use a PEEP of 0 because these patients have clear lungs and do not require PEEP. And for intubation, etomidate is a good choice because it is safe for the blood pressure. The blood pressure does not drop with etomidate. Ketamine is not used because ketamine is also a safe drug for blood pressure because ketamine increases the sympathetic output, and these patients already have a high sympathetic output. In general, ketamine is avoided in cardiogenic shock. And along with etomidate, you can use some fentanyl and a muscle relaxant. So coming to fluids. So as far as fluids are concerned, do not give fluids to these patients. Do not give fluids to these patients unless you think they are grossly hypovolemic or there is evidence to suggest they are grossly hypovolemic. So this is the European Society guideline table 10, which I have put. And as you can see, cautious volume loading, saline or Ringer's lactate up to 500 ml over 15 to 30 minutes. Consider in patients with normal to low central venous pressure. For example, due to concomitant hypovolemia. Volume loading can overdistend the RV, worsen right ventricular interdependence, and reduce cardiac output. So this is very important here. If your CVP is low, relatively low, because CVP will become somewhat high or even very high with acute right ventricular failure. So CVP, let's say, is less than 6, 7, is compatible with a low CVP in these patients. Or if there is hypovolemia, there is clinical suggestion of hypovolemia, patient has not been taking anything, or patient has had fluid losses, then you can consider. Or your IVC is totally collapsing, that is another situation. So do not give fluids in these patients because the patient's RV is already overloaded. Okay, and if you give fluids, you're further going to dilate the RV, further going to increase the wall tension, and the RV is going to deteriorate further. So another way of looking at it is looking at the IVS septum. If the IVS is bulging towards the LV, that is a big no-no. However, if the IVS is still bulging towards the RV, you can try some fluids if you are in doubt. But if the IVS starts bulging towards the LV, do not give any fluids. So that is about fluids. Some literature mentions to give fluids, but do not give fluids because the RV is already failing. If you give fluids, the RV is further going to dilate and worsen the situation. Now, as far as cardiac output and blood pressure is concerned, so it's very important to both improve the cardiac output and to maintain the blood pressure. The blood pressure is very important because the RV perfusion depends on the systemic blood pressure. If the blood pressure is low, the perfusion of RV will decrease. And if the RV perfusion decreases, the oxygenation of RV will decrease and the contraction will decrease, which will further worsen the situation. So at the same time, we have to increase the cardiac output. The cardiac output is increased by giving dobutamine, is the drug of choice. The milrinone can also be used, but generally worldwide dobutamine is preferred. As far as blood pressure is concerned, the drug of choice is noradrenaline. Noradrenaline also increases pulmonary vascular resistance. So that is a slight drawback. The other option is vasopressin. Vasopressin does not increase pulmonary vascular resistance and is a good vasoconstrictor. But there are no head-to-head trials for noradrenaline and vasopressin. And noradrenaline, because it's used in most cases of shock, generally, whatever kind of shock you have, is a go-to drug. The downside of vasopressin is that vasopressin can cause some degree of coronary ischemia due to coronary constriction in patients who have cardiac ischemia, that is coronary artery disease. So you can use noradrenaline. Vasopressin can be tried depending on the situation, but there are no head-to-head trials for noradrenaline and vasopressin, and noradrenaline continues to be the drug of choice. So you give dobutamine and you give noradrenaline. If giving dobutamine maintains the blood pressure well and good, you don't have to give noradrenaline. But generally, if you give dobutamine, some drop in blood pressure is anticipated, and to maintain the blood pressure, you give noradrenaline. Now, as far as arrhythmias are concerned, they are very detrimental. Atrial fibrillation is not uncommon, or you can get atrial ectopics. So you have to manage the arrhythmias with your antiarrhythmic drugs and take the help of cardiology people depending on what is happening. Arrhythmias become important because, especially atrial fibrillation, because the filling of the ventricle becomes impaired and they impair cardiac output. So we have discussed about ventilation, fluids, cardiac output, blood pressure, arrhythmias. What about the role of inhaled nitric oxide and prostaglandins? So inhaled nitric oxide and prostaglandins are pulmonary vasodilators. You don't want to use systemic vasodilators because they will lower the blood pressure. So, there are several reports and small trials which have shown benefit with inhaled nitric oxide and inhaled prostaglandins. So if required, and if you have the experience, you can go ahead and use these substances depending on what the clinical situation is. So this is just some of the evidence in favor of inhaled prostacyclin and inhaled nitric oxide, and then vasopressors showing norepinephrine and use of vasopressin. Now, use of catheter-directed procedures. So catheter-directed procedures are coming up in a big way in recent times. They're used for thrombolysis, wherein you inject a small amount of alteplase into the pulmonary artery near the thrombus. The dose is much less than what you use systemically. Then they can be used for embelectomy, where certain devices are used to retract the clot or pulverize the clot and retract it. And there is off-label use to reduce clot burden in the veins as such, the lower extremity veins also. So with the use of catheter-directed procedures, the risk of intracranial hemorrhage is very much reduced to the extent of only 0.35%. Though with the procedure, there is a risk of 4.6% of a major complication. And these catheter-directed procedures have been approved for even intermediate risk of patients as per the American College of Cardiology 2020 guidelines. Though the European guidelines do not recommend treatment for intermediate risk patients. So when is pulmonary thrombectomy done? So pulmonary thrombectomy is done when thrombolysis is not possible or there is failed thrombolysis. And this is done only where there are centers who can do this. And this is an open surgery. And like I said earlier, sometimes can be catheter directed also. Now coming to VA ECMO, so VA ECMO is used in extreme cases like refractory shock or cardiac arrest. And VA ECMO alone is not sufficient. VA ECMO mainly supports the circulation. You have to have some form of primary therapy needed along with ECMO. So now coming to a slightly controversial area, that is the treatment of moderate or intermediate risk pulmonary embolism. So some trials were done for this, namely MOPET and PETHO, and there are guidelines from American College of Cardiology 2020, which say that a low dose of alteplase can be used, low dose being 50 milligrams safely in these patients, and the rationale being that they lead to lysis of the clot and prevent the development of pulmonary hypertension in future, and this leads to overall better outcomes. However, this low dose or 50 milligram alteplase in moderate or what is also called intermediate risk pulmonary embolism remains an area of controversy. And coming to the second issue, that is the deep vein thrombosis. So, pharmacomechanical catheter-directed thrombolysis is advocated by certain trials for these patients because this actually dissolves the or lyses the clot in the deep venous system in the limbs, and this leads to better outcomes. So this is what you actually get if the clot does not resolve in the extremities in your legs. It's called the post thrombosis syndrome, and this is seen in a significant number of syndrome patients. And that is the rationale behind pharmacomechanical or catheter-directed thrombolysis in the extremities in these patients to prevent this post-thrombosis syndrome. Because the classic site for thrombus formation is near the valves, the venous valves, and the venous valves get destroyed. So there is insufficiency. The venous return becomes insufficient. There's dilatation of veins, and they develop venous edema in the legs, and even stasis ulcers, venous stasis ulcers. What is the role of IVC filter? So IVC filter is something which is used if anticoagulation is contraindicated or if there is an embolism on anticoagulation and the patient cannot tolerate another episode because of previous pulmonary disease. The filters do not improve outcome. That is what studies have shown. And DVT can still occur despite IVC filters because you generally are not anticoagulating these patients, and emboli can pass through the filters. So filters, the main indication is if you cannot anticoagulate, you can use filters. And this is just a picture showing you an IVC filter here. Now, PE in the perioperative period. PE in the perioperative period, with surgical patients are predisposed to thrombi, and you have to stop low molecular weight heparin before surgery if they develop DVT or pulmonary embolism before surgery, and start heparin. Heparin's life is 6 hours after you stop it, so fast switch off you can have with heparin, and 12 to 24 hours post-op you can start therapeutic anticoagulation. Thrombolysis cannot be done for 2 weeks post-op. So that is about PE in the perioperative period because surgical patients are prone to developing thromboembolism. What about pregnancy? Another situation in which there is pulmonary embolism. So here during pregnancy, you can use low molecular weight heparin and you have to switch to heparin before delivery, and you continue anticoagulation for 3 months after delivery, and thrombolysis is preferred to surgery during pregnancy if there is pulmonary embolism because there is less risk, though thrombolysis also carries significant risk. And there is a lot of morbidity around pulmonary embolism during pregnancy with 15% significant bleeding and 10 to 20% fetal loss. Now coming to COVID-associated coagulopathy. So a few words about that. COVID is here to stay, though the storm has passed. So in COVID, there is hypercoagulable state. Platelets, PT-APTT, fibrinogen, D-dimer are either increased or normal, and TEG shows a shutdown of fibrinolysis. Bleeding is not a feature of COVID. Please remember that. So there's a hypercoagulable state because of the alteration in the coagulation factors and pathways. there's an endothelialopathy, and this is driven apart from COVID virus. It is driven by the hypoxia. So hypoxia drives hypercoagulability and endotheliopathy apart from the COVID virus itself. And this leads to macro and micro thrombosis, and pulmonary embolism can occur in these patients, and DVT can also occur. Now, upper limb DVT is another thing which occurs, and it is not so uncommon, mostly secondary to lines and devices. And the treatment is anticoagulation and consider catheter-directed thrombolysis before considering any surgical decompression. Catheter-associated DVT does not necessitate removal of the central venous catheter, provided you go in for some kind of a treatment modality, and anticoagulation should be continued for 3 months. Now, patients sometimes come who have pulmonary arterial hypertension or who have chronic thromboembolic pulmonary hypertension. That is, they are patients who had previous pulmonary embolism and they have developed chronic pulmonary hypertension due to this thromboembolism. So how do you diagnose acute pulmonary embolism in these patients? So first of all, if you get McConnell sign is specific for acute deterioration, that is acute rise in pulmonary pressures. Second is features on ctpa can help to distinguish whether there's a fresh emboli or there are old emboli. And if still in doubt, you can go in for pulmonary angiography. So these are features which help to distinguish chronic pulmonary thromboembolism from a patient who has had a new episode of pulmonary embolism. And a patient of pulmonary hypertension, you'll have to do a CTPA, and CTPA will demonstrate your embolism, because these patients have pulmonary hypertension because of etiologies other than chronic thromboembolism. Now, can you get DVT on oral anticoagulation? Yes. Despite being on oral anticoagulation, you can get DVT. It is not so uncommon, depending on what is the coagulation status, coagulation pathways. Do we need anticoagulation in liver disease with high INR? So, liver disease is a situation where there is balanced rehomeostasis. There's alteration in the procoagulant and anticoagulant factors and pathways. So there is a tendency towards clotting in liver disease. There's a risk of clotting, and there's a risk for DVT also. But generally, we do not use anticoagulation in patients with liver disease because there's a risk of bleeding also, and INR is high. What about pulmonary embolism and cardiac arrest? So if the patient develops cardiac arrest because of pulmonary embolism, as will be demonstrable on echo, when patient has a cardiac arrest, you revive him, you get Roski, you do the echo, the RV will be dilated, give 50 milligram alteplase, stat, and another 50 milligram after 5 to 10 minutes, and do your CPR. Prolonged CPR is done for these patients for 1 hour because it takes that much time for alteplase to dissolve the clot. So prolonged CPR has to be done in these patients, and 50 plus 50 milligram of alteplase is given rapidly. Now, when can a patient walk without fear of dislodging the clot? This is a common scenario. Patients develop a DVT, and the question is, can we ambulate the patient? So studies have shown that you start the anticoagulation, and within 12 hours, the patient can be mobilized. The clot is not going to be dislodged by making the patient mobile. That is what has been shown in the studies. There's no increased risk of dislodgement of the clot and pulmonary embolism after DVT once you start anticoagulation, and it is safe to make the patient ambulate. Now, what are the high-risk groups? So high-risk groups are neurosurgery, orthopedic, paralysis, pregnancy, cancer, thrombophilia, previous DVT, obesity, and patients on oral contraceptives. So coming to bedridden patients at home, we often discharge patients who are going to be bedridden at home for prolonged periods of time. So do we anticoagulate these patients? So the answer is no, we don't have to anticoagulate these patients because it does not alter the prognosis. And why it does not alter the prognosis is because these patients have underlying comorbid diseases, serious diseases which predisposes them to death. So by giving them anticoagulation, you do not prolong their life. So the answer is no, do not have to anticoagulate these patients. Now coming to DVT in situations like stroke. So stroke has multiple causes, and there can be all kinds of stroke from minor to major. So it is best to let neurologists decide. It's a complicated scenario here. Superficial vein thrombosis of lower extremities and calf DVT have to be treated with anticoagulation, for therapeutic anticoagulation. There should be no controversy. Earlier literature used to say that these patients may not be anticoagulated, but they have to be anticoagulated. Now coming to DVT prophylaxis, the DVT prophylaxis, you use standard dose of enoxaparin, 40 milligrams subcutaneous, and if you cannot give, then use DVT pumps. The role of DVT stockings, physiotherapy, early mobilization, and ambulation is questionable. Now coming to the last couple of slides, just to summarize. So if there is hypotension and you suspect pulmonary embolism, what is to be done? Start anticoagulation, okay, therapeutic anticoagulation in the form of heparin or low molecular weight heparin. Do the echo and try to establish the diagnosis. There has to be wall dilatation, your RV dilatation. If there is hypotension due to pulmonary embolism, try to do a ctpa to confirm the diagnosis if possible, if the patient is shiftable. Thrombolysis, if either echo or ctpa is positive. Consider CDT as required, and you can use low dose alteplase CDT in intermediate risk patients. This is controversial, however, and concomitantly manage acute right ventricular failure. At the end of the day, please remember, prevention is better than cure. Always use anticoagulation when the patient is in the ICU. And these are the guidelines which are readable, and you can refer to these. 2019 European Society Cardiology guidelines are the most comprehensive and the latest in a way, and most of the data on treatment and risk stratification is from here that I showed you. And then you have American College of Cardiology, very brief guidelines, especially on intermediate or submassive embolism, where they recommend treatment. And then you have American Society of Hematology 2020 guidelines. So with that, I thank you for your patient hearing. And if there are any questions, I'll be happy to take them. So there are no questions, so I shall end this. It's okay.